And I am really excited to welcome Dana Hutson to the stage, who is going to lead us on a discussion topic that seems to have a theme in everything that we do. And almost every discussion that we have on here, somebody brings up a situation where they are, either interacting with a healthcare provider, or more often than not, they or their loved ones find themselves suddenly in a hospital and they have to make split-second decisions, and they're waiting around, for hours for a doctor to come in and tell them what the next step is. And then, it can generally be a pretty pressure-filled situation here. So let's see. Dana, I think you got your mic open. There we go. All right. The great seeing you. And I'm thrilled to have this discussion. And so as I was just leading up, the role of your profession, which we're going to learn about, patient advocate, is just that. It's helping people through these challenging situations that oftentimes they never imagined themselves being in, and now they have to make split-second decisions. And the other day, or a few months ago, I was sort of finished one of these discussions and happened to see Dana, and I was like, man, we could really use you to sort out some solutions for our community here. So before we dive into this, Dana, for those in the audience that don't know you, tell us a little bit about yourself and what got you into this profession.
Yeah, thanks, Steve. Thanks for having me. I'm humbled to be here. I am not a clinician. I do know Brittany Lamb, though, the gal, the ER doc. She's going to be great. You guys are going to love her. I'm not a physician. I'm not a nurse. I'm not a clinician. I am a person that worked in pharmaceuticals and biotech in the healthcare industry for over 25 years, until just recently, within the last 5 years. And I had interactions with the healthcare system, with my own family, friends, that just prompted me to look into the profession of patient advocacy. So that's how it's a very difficult system to navigate. And I thought I'll take my skills and go over here and try to help people.
Yeah, and I mean, I think if there's one profession that you probably, I mean, it's challenging because you're working with families in some of the most difficult situations, but the feeling that you and your colleagues who are patient advocates must get in terms of helping people understand that they have choices when a lot of times they don't think they have any choice, and that's I think what I hear more often than not is that the that the doctor or the healthcare professional says this is what you need to do, and they might not even be saying that. They may be giving choices, but what the consumer hears is, I've got to do this, and then after the fact realizing that they had a lot of choices.
Oh, Steve, I've got stories. I'm going to tell y'all stories today. I've got stories. Yeah.
Well, let's people don't need to hear me. So this is what I'm going to do is dive behind the curtain here. Let you you've got a presentation that you're going to walk everybody through, but I want to remind everybody in the audience that this is interactive. So at any point in time, you have a question, type it in. And then Dana, if you want to take a few breaks and check in with me, and if there's anything on the radar, I'll make sure to let you know.
Yeah. Thank you, Steve. And these slides, y'all, are just meant to guide our conversation. So I don't hesitate to jump in and interrupt. And I will be checking in with Steve to make sure that your questions get answered. So I'm going to go ahead though and share my screen and go ahead and use these just as a guide. We've already talked about me, but let me tell you just a little bit about me, why I feel like I'm qualified to give y'all this talk. This gentleman right here, this is my granddaddy. This was a picture taken in July of 1958. He for anybody that lives in the DC metro area and are familiar with Virginia, he's actually the medical director at Lorton Prison back in the 50s. So he was in medicine. My grandmother was a nurse. I really thought I would follow in his footsteps. I loved the whole doctor thing. I used to play doctor all the time, loved it. Got to school, went to organic chemistry, and was weeded right out of the program, just like that class is designed to do. But I never lost the love of medicine and science. So I went to corporate, and I took my business skills and I went into corporate pharmaceuticals, biotech for over 25 years, spent time there in all manner of jobs. And then this gentleman here is my dad, and he was diagnosed several years ago with a rare bile duct cancer. And my perspective on the healthcare system went from delivery to I was a recipient. I was engaging with the system now as a daughter, as a caregiver. And it was during that transition that I really realized there's a gap in our healthcare system. It's confusing, it's disjointed, it's fragmented, and people just need help. So I went and sat for the board certification to become an independent patient advocate, which is what I do now. And I started my company, Cancer Champions, 5 years ago to help people navigate through a difficult cancer diagnosis. So that's me. And that's why I feel like I have insight and perspective to share with you all today. So because my role, I have heard so many times from people, gosh, I wish I had known this. I wish I had known that. I would have done this differently. And we have choices as a healthcare consumer, but we also have a lot of questions. And so I'm hoping by the end of today, what we're going to know is why we're in this situation that we're in, why we have to shift our mindset from sort of just somebody that's just receiving whatever the healthcare system wants to give us to strategies that help us to be a more engaged healthcare consumer, and to find your voice and to know that you have choices and to be able to advocate for yourself when the white coat comes into the room and everybody gets paralyzed and just thinks they need to listen to the white coat. That's not necessarily the case anymore. So that's what we're going to cover in these next few minutes. And there's a lot here, so I'm going to be kind of high level, but there will be a resource at the end of this that I'm going to provide, that Steve's going to put up on the site. That'll be a complimentary sort of summary of the high points and the links and the things that I'm referencing in this talk. So unless, Steve, there's something else, and if there's something else that somebody would like to be, that they would like to see addressed but don't see it, just type it in and let Steve know.
I love it. No, we're good to go. This sounds like a great plan, Dana. Okay,
perfect. So let's just go ahead and get started. I just want to go back. So Granddaddy, this is a picture of him, and he is actually like, this is one of his patients that took a picture of him as he was on his way to a house call. I mean, who even knows what, like if I told my kids about a house call right now, they would not, they would think it's a party or something. They wouldn't know what was going on. Medicine is not like it used to be. Granddaddy knew his patients. He knew their families. He knew their social situations. He knew their health habits. He knew them. And so he had and physicians like him, not just him, but his era physicians had a deep connection with their patients and with their patients' families. They saw them on a regular basis. And I mean, when you're trusting somebody in your most vulnerable state, when you're sick, there just is a bond there that develops. We don't have that anymore. This was probably back in the 40s, maybe the 30s. This is a hospital ward. You can see there's one doctor, there's a patient, there's one nurse, there's a med student, there's one nurse, there's one doctor, there's one patient. Like, it was a one-to-one. Your family practitioner, your general practitioner, they admitted you to the hospital, and then they rounded on you. They came and saw you in the morning, they saw you in the evening, the nurse took care of you all day. Well, fast forward to today, this is this is a little bit hyperbolic, but not really. I mean, we have so much technology now, so many systems, so many things to help us. A nursing station in the hospital today, really almost looks like they could launch a space shuttle. So it's very complicated. And what that has led to is confusion for a lot of people. We've got all the technology, we've got medication. Now, I am my personal bias is I think the United States has some of the best healthcare in the world as far as the resources we have and the research and the innovation. What we have, though, is a broken system to deliver that stuff. And so we've got a lot of sophisticated medications. We have lots of tests. So think back to the granddaddy picture. Granddaddy knew his people so well that when they came into the office, he could almost look at somebody. And a lot of those physicians back from that era had very good critical decision-making skills. They could just look at people and start thinking of a differential and what may be going on with that person. Today's physician, not to take anything away from them, but they diagnose everything with tests. They have a test for everything. And a lot of times they are managing the test. They might not even look at you. They're looking at the computer. And then we also have lots of physicians. So no longer do you have the one physician that's just sort of taking care of you and knows you really well. You've got a specialist for the lungs and one for the brain and one for the heart and one for the bones. There's a specialist for everybody. I see there's something in the Q&A. Steve, is it something that, can I help somebody right now?
Let's see. It says, this is Rebecca, and she says, Dana might tackle this question during her presentation, but just in case she doesn't, are you an advocate for other illnesses apart from cancer? And do you advocate for only the elderly population or any age group? Great questions. And I knew they were going to come up because of your company name.
Yeah, no, it's, you know what? And I should have addressed that. Thank you. I do just cancer. And the reason being is because that's where I spent my entire career. So I have lots of resources, network. I have a lot of knowledge about the disease. I can go really deep there for somebody. There are advocates, which we will address at the end, that advocate for all different diseases, all different types of medical situations. And you can get people that are very specific like me, or you can get people that are very broad. To answer your question, I do elderly, I do children, I do everybody in between. But usually for me, it's a cancer diagnosis. So I hope that answers the question. But I'm going to give you guys a good resource how to find an advocate at the end. Okay, the other piece that's happening is our system, COVID has did a number on the system. So we have a lot of clinicians are leaving healthcare. They're retiring, they're leaving. The ones that are left are stressed out, they're tired, they're frustrated. And so we have this sort of perfect storm of yuck going on in the system. And so something's got to change, y'all. But I'm going to say this. I love Einstein's quote. We can't solve our problems if we keep using the same thinking that we use to get there, to get ourselves in this mess. So we're going to have to think differently. But I'm here to tell you, it's not the medical schools that are going to think differently quickly. That's like turning the Titanic, right? So what can we control? We can control ourselves. So this whole talk today is really going to challenge us to change our mindset from just kind of going along and letting the doctor drive, and the doctor just kind of tells us what to do, and we just start, following along as his passenger, to shift over into, we need to be the navigator. We need to be the advocate for our own health. And yes, let the physicians drive because they're the ones with all the medical knowledge. We're not doctors. So we have to trust their training and trust their knowledge, but we can give them a little direction when it comes to what our goals are and the path that we want to take. So that's going to be what our focus is. And I'm going to shift into those 5 areas, those 5 strategies that we really can start to initiate right away. So the first thing is to change our mindset from being, I don't know anything about medicine. She's got the white coat. They must know more than I do. I'm just going to do what they say. Kinda. Like, so that is true in the sense that they have more training than we do, but we know our goals, we know our values, we know our body better than anybody. So we need to engage and become a more informed healthcare consumer. So how do we do that? So the first way is to just educate yourself, kind of just know about your illness or know about your diagnosis. Now, this talk, just to let y'all know too, there are two sides. There's the healthcare system that is not urgent, right? Where you're just going to the physicians in an outpatient situation. And then there's a very urgent, I'm in the ER. Oh my gosh, now what do I do? I tried to meld a little bit of the two together. I think if we practice being better consumers when we're not in an emergent situation, we will be better prepared when we are in an emergent situation. And I have a talk all about what to do in the hospital, and that can be a different talk, but I'm trying to marry the two today. So one thing that you can do is, if it's not an emergent situation, but it could be an emergent diagnosis, like people that I work with, they're fine one day and the next day they have a cancer diagnosis. It's pretty emergent. You can start to choose your doctor, choose the clinic, what kind of a healthcare hospital do you need based on what you're facing. So you can do that research. You can also prepare for your appointments and ask really pointed questions of the doctor, of the pharmacist, of your insurance company, questions that are going to help you make better decisions. And finally, you don't have to do what the first person you see says. We have the freedom and the choice to go and get independent opinions. And sometimes an opinion should be gotten, a second opinion, even if it's just maybe you trust what the person is saying and you feel like they're competent, but you just don't meld. So you don't feel like they're listening to you. You don't feel heard. You don't like the practice. You don't like the way the nurses are treating you. Then that's fine. There's another person you can go talk to. So we should be as discriminate about our healthcare, who's serving us in our healthcare situations. We do more analysis, quite frankly, when we're buying a car. I'm just saying, we need to flip that switch in our mind. What do we all do when there's a gap, when there's a learning gap and we're faced with something that we don't know? I mean, maybe some of you don't do this, but I know I do it, and almost everybody I know does it. We get on the internet and we start doing research. It's a beautiful thing to have all of that information at our fingertips, but it can also be a place to really be careful, and it can sometimes be harmful because not every site is vetted. Not everything on the internet is true. And so we need to become better consumers of even the information. And so how do you do that? Well, you can ask your healthcare team, what sites do y'all use? Because trust me, they're having a hard time keeping up with the information just as quickly as we are. So what sites do they recommend that you look at that are vetted? And then once you get there, you have to look at the information that you're gathering and ask yourself, is this good information, or is this maybe fiction? Right? There's a lot of fiction on the internet. And some of the ways that you can do that is looking at how large the study is. If it's one or two people and they got a response and nobody's controlling for any other variables, and that might not be something to hang your hat on. You want to see where it's being published. It should be published, and you should be able to find all this information in the research. If you can't, then they're hiding something. So you want to be careful. Has it been put in a peer-reviewed journal? That just means that the article went to an editorial review of a bunch of other physicians and researchers. They looked at it. They think the data looks good. They checked out the data. It's sound. And then they published it in their journal. If you can't find out who the authors are on a paper, that's a problem. They should be able to tell you who's behind this information. And unfortunately for my clients, I have a lot of people that are desperate for cure, frankly. And if it sounds too good on the internet to be true, 9 times out of 10, it probably is. And unfortunately, there are a lot of people that prey on people who are desperate. So you just have to go in eyes wide open when you're searching and researching on the internet. And then when you do take this stuff to your physician, I love this thing. It says, please don't confuse your Google search with my medical degree. We still have to remember these people trained for years and years and years. So it's okay to take your research to your clinician, but just know that they know more about our illness, not about us, but about our illness than we probably do. Is there anything, Steve, going? Should I?
Well, actually, I think that I'm not sure if you have a resource for this, but somebody was, but this is a good one for other audience members, is can you suggest a resource to compare original Medicare with Medicare Advantage plans? I'm going to drop that into the chat.
Yeah.
So if anybody in the audience has a resource in that area, but I didn't know, is that something that you help folks with or other patient advocates help folks with?
That's a great, so there, and this is great. I love that people are thinking like this, because this is part of being a better healthcare consumer, right? You got to understand your plans too, because then you know what you can access. I don't do this specifically. I help people understand their plans based on what their options are for treatment within a plan once they have it. There are advocates that do nothing but insurance and helping people get the best plans. I know several people that I could refer people to, so I will make sure that I let you know, Steve, who those folks are. But there is a huge difference in like an HMO plan within Medicare versus the PPO, like Advantage versus another supplemental. And it depends on the values and the goals and the objectives that you as a consumer are looking for. So I'm not going to say one is better than another. It just depends on what you want. Okay.
Okay, great.
All right. So we're going to research. The other thing that I want people to do is get the best hospital and the doctor for what you are facing. So what do I mean by that? There are websites that have been vetted that actually do ratings for hospitals, and they'll do ratings based on, I'm just going to share with y'all right now. We drive around the Beltway here and you see those huge banners hanging off of they're hanging off all the hospitals, best this, best that, best this. They're on all the hospitals. And it's US News and World Report. That is a marketing tool for that health system. Now, it's not to say that that's not a good hospital or they're not the best in this, but you have to understand, what are they rating them on? And in some of those surveys, they are rating them, patients are rating things on the parking, the coffee shop, how good the food was in the cafeteria, how clean the place was. But it has nothing to do with the skill set of the people that are operating on people inside the building. So just know that and like the Washingtonian and the best of, there are some really great physicians in that thing. I'm not saying they're not, but it's a marketing tool. And I know some physicians that have paid up to $10,000 to have their thing on a page in the middle of the Washingtonian Best Docs. So let's just not make that our sole criteria for how we're going to choose things. Let me give you an example. This is the first one that I showed you. It's Leapfrog. They are a third party. They're a nonprofit, and they have this hospital safety grading system. So if, let's say you're going to go in and have a hip replacement and you just want to see, how does the hospital rank in falls, in infection rates, and some of the other things that should never happen to you while you're blood clotting, things that should never happen to you in the hospital. You can go and put your zip code in, put in a radius of geography that you're willing to travel to. And when you hit the search, for me, this particular zip code, there were 37 hospitals within 50 miles of this zip code. When you go down here, you see this big B. This particular hospital got an overall rating of B. Now, the rating system goes from A to D. You can go into the hospital safety grade and see specifically how this hospital did with falls, with infection rates, with blood clots, medical errors, medication errors, all of these things. So do your research is all we're saying. There's tools out there for you to use. And then getting a second opinion. So a lot of people, especially in my parents' generation, they were afraid to make the physician upset. They didn't want to get a second opinion. They thought the physician would feel, that that was bad. I'm here to tell you that if you've got a doctor who gives you a hard time for getting a second opinion, that is all the reason why you should be running to get a second opinion. Any of these guys and gals should be happy for you to get another opinion. And what do I mean by independent second opinion? Let me give you an example. So you're going to go get your hip done. And let's say you're in the Inova system, you're going to Inova Orthopedics, you've got this person's told you this is what they want you to do, but you just want to get a second opinion. So if you go to another Inova Orthopedic person, 90% of the time, guys and gals that are within the same practice or within the same health system, they're going to corroborate each other. They're not going to go against what somebody else said. So what you want to do is take your diagnosis and yourself maybe over to like MedStar or Anderson Clinic or somewhere outside of Inova, get a second opinion and just compare and compare a lot of things. It's not just their skill set, but do you kind of get along with them? Do you feel like they listen to you? So it's okay, get a second opinion. Okay, so now we're going to move. I'll be quiet for a second. Steve, is there anything? There's some chatting and some Q&A. I just want to make sure there's.
Yeah, actually, there was a pretty good question. It's in your experience, how important is it for a doctor to be skilled with palliative care? And I imagine with your clients, this is something that is very key. And also for those that might not know what palliative care is, maybe give a real brief introduction to that.
Yeah, that's a great question. And palliative care is not just for cancer. It's for any illness, a chronic illness that causes people symptoms and pain. And palliative care is a specialized branch of medicine where there are usually physicians that are very skilled in pain management. You also have access to a nutritionist, so can deal with nutrition. You have access to people that do symptom management, nurses that are specialized with symptom management outside of pain. And then you also have social workers and people that can help connect you with resources. So what a palliative care team does is it addresses the whole, not just the patient, but also the social needs of like a family and how illness and chronic illness affects a whole family. Palliative care is a layer of support that comes in to help with all of that. So that's a great question.
Great.
Okay. So the second stage of becoming a better advocating for yourself is keeping track of your personal health record. And this is probably, I'll just tell a quick story. So we think, well, let's back up. Back in the day, in Granddaddy's day, files, big fat files and the big, metal file cabinets. And like he could go back and tell you everything that had happened for our whole family all the way back, generations. Okay. We don't do that anymore. Now the government has basically told all the healthcare system that it needed to have an electronic medical record. And the intention was really good. The intention was that it would be so connected that anybody could go anywhere and all of your medical record was there and everybody would be connected and informed. What happened in real life, there was such a push to do this. There were about 5 medical record companies that started selling EMRs, electronic medical records. And they would go to the doctor and they would go to the hospital, and these different companies were competing. And you had physicians and hospital systems, choosing one of the 5 of these things. And then what happened is people started merging. Inova started gobbling up hospitals. Physician practices started merging together, and they brought with them their electronic medical system, but they weren't integrated. So if one uses Epic and one uses something else, your records are an electronic medical record, but it's in 2 different places and they're not talking to each other. So we cannot assume when you go to the hospital, if you show up in an emergency room and you've never been to that hospital before, they can't find you. You're not in there. You're not in there. And if you go to a physician over here in Falls Church, but now you have to go to a specialist in Reston, they may not be able to talk to each other. So it's incumbent on us as the consumer to know our medical history and to have our medical record. And that's a big job. So there's patient portals for each one of these electronic medical records. It's important that you set up your portal, that you know how to work your portal, because that's how you go and get a lot of that information. Because like I said, it's not all talking to each other. And also, as you go forward, do not leave a hospital after you've had an x-ray. Do not leave until you go and get the disc for that x-ray and the report. You want the report, the paper report, and the image before you walk out of the building. They can burn it for you right there. So don't leave hospitals or doctors' offices without getting the reports and the imaging, because it's a real hassle to go back and try to get it. But if you get it right when it's happening, it's good. And I don't care how you take notes. I don't care if you use a notebook. I don't care what you do, but do not interact with the healthcare system ever without documenting what's being said. That's just, we need to keep track of what's being said. And I'm going to give you an example of how this comes into play. These are some of the things you want to make sure that you have documented, right? You just need your past medical history. If you don't have a power of medical attorney, you need to get one, because we could be rendered incapable of speaking for ourselves at any given time. And so let's just make sure that somebody knows exactly the kind of care we want to have to make sure we're getting what we want, and we're not leaving people guessing what we want. You want to also have all your health insurance details. You guys can read what you want here. These are just the basics of what you need to start out with. And then I don't care how you I don't care what your record keeping is. Some people like files, some people want notebooks, some people like to keep things on, a USB and then just pop it in. There's lots of ways to keep your records together. And there's actually a lot of apps out there now. This is just an example of one where it won't go get the information for you, but once you have the information, it's a place where you can keep everything together and you can share it with family members or whoever you feel would need access. So that's the second piece, like to keep the notes and to keep your records. Now, the third piece, this is a shift. This is a mind shift, because usually the GP, the internist, the family doc, the granddaddy was the quarterback. He kept track of everything. So if I needed a surgery, or if somebody needed an ENT, or we needed something, the general practitioner was the one coordinating all of that. And then he was the one, everybody would report back to him, and then he would sort of manage what was going on. That doesn't happen now. If we need a specialist, we go to the specialist, and if we need another specialist, we go to that specialist. They don't talk to each other, and nobody hardly ever calls and talks to the GP anymore. Like, that poor person hardly ever gets a report. So we have to be organized, and we have to be like the coach of our team. So what do coaches do? Coaches have a plan. We need to have a plan. So before we go into our doctor's offices, we want to know what's our goal, what's our objective, what is the plan for this appointment. And this also gets back, Steve, to what you were saying, how, sometimes we may only have 8 minutes with these people. So you want to maximize the 8 minutes that you have, which is, I'm just going to sidebar, which is why you don't want to walk into them with all of this research from the internet that doesn't make any sense to your case, right? And then have him spend 7 of the 8 minutes telling you why that research doesn't apply to you. So it all kind of fits together. You want to be able to share your health history with everybody you talk to. So if you go to the GP and he says you need to go to the cardiologist, you go to the cardiologist, you need to be able to tell the cardiologist about your health history. You can't assume the cardiologist is going to pull something up on a record, or assume that the GP had a conversation. So you have to be prepared to tell them with everybody. That's all the specialists that you might see.
I don't want to derail the conversation, but you said something that really reminded me of my dad, who's an engineer by training and had a procedure in the hospital. And he found that it was just exhausting because he had to repeat himself every time when somebody new came into the room. And so I forget if he did this before or he may have done it during, where he asked for his computer or a notepad, and he just created this sheet
His clinical
where
summary.
now he would basically hand it to the practitioner that would walk into the hospital room, and he'd request, could you take about 10 minutes and look at that and then ask me if you've got any questions? And I was in there for one of the situations where he handed it to somebody. And I was impressed by the physician, because what the physician did was he read it out loud, and they started to have a conversation on all of those elements there. So just a little sidebar there on
The awesome sidebar. And can I just say, Steve, that's sort of like a clinical summary. That's what they call it in the medical world. So you actually could write your own sort of clinical summary, but I bet what you experienced was a more engaged doctor with your dad. So the more prepared we are and the more we can be engaged with them, you get more time with them. 100%. That's awesome, Steve. Thanks for sharing that.
Yeah, and I think also that we find what I hear when I talk to members of our community is that you've repeated your, like, it can be very frustrating for a patient to go into detail on the situation, and then somebody comes in the room and they don't know anything, and it's exhausting, and then you stop sharing as much.
Yeah. Yes.
And that could impact your situation.
Yeah. And you also don't feel heard. Like you're just like, is nobody listening to me? Like, is nobody, like, what is happening out in that hallway? Is nobody talking to each other? My dad got so frustrated because they ask you, you know, to show your armband so they can be careful with the medications. And they kept saying, what's your name? Show me, you know, what's your name? What's your name? And my dad was like, after 5 days, he's like, excuse my language, this is my dad. He goes, damn, Dana. He goes, nobody even knows who I am in here. What am I doing in here? And I'm like, Daddy, it's redundancy. It's like there for safety. But if you don't know, I mean, it's crazy. Anyway, it's crazy.
Yeah. All right. Well, let you get back.
Yeah, we're going to blow through. So you want to prepare, you guys, you want to have a plan. How do we do that? Okay. This is the story I wanted to tell y'all. This happens when you go to the hospital. Okay. A lot of people don't know who a hospitalist is. They've never heard that term. And unless you've been in the hospital, you've probably not heard this term. Back in the old days, remember the granddaddy slide, he was putting people in the hospital, and then he was going to take care of his patients in the hospital, and the occasional specialist would come in. Now, your GP, your internist, they don't even have hospital privileges. Those guys don't step foot in the hospital anymore. We have a person in there now that's an internist, usually, that is called a hospitalist. And what they do is they manage people while they're in the hospital. They don't have a practice outside of the hospital. Their sole job is just to manage people's cases inside the hospital. They operate as the internal medicine person, that sort of GP. They quarterback the care of all the specialists. So what do we think about this person? Never seen us before, has an electronic medical record that probably isn't telling them very much, don't know us from Adam, don't know anything about our history, don't know us at all, and are going to see not just me, but probably 15 other people today, right? How much do you think this guy is or girl is really engaged? Not much. So this is the precise reason, like what Steve was just saying, why we need to have our medical history, or at least a summary of what it is that we're dealing with right now, from the time that the diagnosis happened up to wherever you are, the date. Because this hospitalist, if you're in for 10 days, this hospitalist is going to be around for a couple days, then he's going to go off. Then you're going to have a new one who is probably, you're going to have to tell the story all over again, to Steve's point. So we want to know who these people are, and you want to make sure that you're giving them all the information, because you cannot assume they know anything about you. And then it is so important for us as consumers to say, what is the plan? What's the plan? Sometimes the plan involves several people, like a team, right? So being the coach, you need to make sure everybody's got the same plan and the plan all fits with the ultimate goal. And you need to know what that plan is. You don't want things just happening to you. You don't want them just to come get you to go down for an MRI at 11 o'clock at night. And you're like, what, why are you doing this? You want to know what are they doing? You want to know what their goal is, what medicines are they prescribing? Why are they prescribing them? All of these things. And it's important for us as consumers to share what our goal is. I want to share one quick story. I had a lady, she was an older woman that was going through a breast cancer diagnosis. And she was old enough that nobody would expect her to have school-age children at home. Okay. But she did. She was a grandmom, and she was the sole caregiver for these 3 school-aged kids. So the doctor, the oncologist, the white coat, right, is busy going, you need to do this. Okay, you got to go have a lumpectomy, then you got to have some chemo, then you got to have radiation, then you'll be fine. And nobody stopped to ask her, like, is that okay? And how is that going to work with your life? Because she was older and nobody thought that, she had any issues. Well, this woman, with my help, we had to say, excuse me, that's not going to work for us, because she can't be nauseous. She can't be sick. She takes care of these little kids. So that's just an example of how we can just sort of push back on them a little bit and say, that's not quite going to work the way you're describing it. How can we change that a little bit so we still get the same outcome, but maybe not in that way? And then there's so many people, there's so many people usually that get involved. So the thing is here, just know who they are and what their role is on the team and how you can access them. Get their contact information. Don't let anybody leave a hospital room without getting their contact information. And also the contact information when you leave the office. Find out, get the nurse's phone number, get the radiology person's phone number, get the pharmacy phone number, get all the information you can while you're in the office so you can connect with people on the outside. And this is a huge one, you guys, the tests. Oh my gosh, the tests. So if we go to a cardiologist and he orders a chest x-ray, okay, but then you're also going to a pulmonologist because they're trying to work up whatever's going on with you. So you're over now at the lung doctor too. And the lung doctor says, I need a chest x-ray. And you just had the chest x-ray 2 weeks ago for the cardiologist. Do not just say, okay, and head on back over to the imaging place to get another chest x-ray, because 2 things could happen. One, your insurance company might look at this and say, you know what, you just had a chest x-ray. We're not paying for that. And now you're on the hook for this test that was ordered that the insurance company is not going to pay for. So what we need to do is say, excuse me, but the cardiologist just ordered this test last week. Can you not use that film for whatever it is you're looking for? Now, the answer might be no. I mean, it might be a completely different kind of imaging because there's a million different kinds of imaging. But in 9 times out of 10, he'll be like, oh, yeah, sure, I can use that. But the cardiologist is not talking to the pulmonologist on a regular basis. So nobody is reconciling who's ordering what tests. So we have to keep track of this. This is a lot, you guys. I mean, this is a job. It's not. So that's why it leads me to this. Don't do this by yourself. Find a care partner. Find somebody in your family or a friend that you trust, somebody that can go on this journey with you, somebody that can go on appointments with you, somebody that can help you gather all this information, somebody that can help you formulate questions, because it's too much for one person. And the truth is that we forget 80% of what the white coat tells us, whether we're in an emergent situation or not. So I go from my routine, physical, and by the time I get to the parking lot, I've forgotten 80% of what she told me. I mean, that's just that there's documented research for that. So don't do this by yourself. And the other piece of this is once you finally have done all your research, you've connected with the right clinicians, you know what the plan is, follow the plan. Like, ensure that you have all of your instructions. I ask people verbally, get it verbally, but also write it, or even record it is even better. Get your instructions, know how to execute the plan. When things aren't clear, ask a question until it becomes clear. It's fine to keep asking questions. Don't screw around with medicine. Like, take it the way they told you to take it. If it tells you to take it with food, it's for a reason. So take it the way it's prescribed. And if there's anything unusual, ask your doctors, what should I expect? What should I be looking for? When should I call you? Because a lot of times we can nip things in the bud if it starts to happen at home, before it gets full blown and you find yourself in the ER. So pay attention to your body, pay attention to what's going on. This happens all the time. Physicians have a vernacular. It's complicated. It's Latin, and most of us don't understand it. They have a tendency sometimes, especially when they're rushed, to fall into their vernacular. So they start talking. Many of them have very heavy accents. They talk very, very softly, or they talk very fast, and they have all these words. So if you don't understand what this person is telling you, this is the person that has the most information about your disease. This is the person that has the most knowledge, skill, training to do something about it. So don't let this person leave the room until you absolutely have tapped everything you need and gotten all of your questions answered from this person. And then drugs, Steve, we could do a whole talk about pharmaceuticals. So all I'm going to say about this is there's a lot of drugs. I am a believer in holistic and drugs, which is more of a complementary approach. But you need to pay attention to what medications you're on, because it gets back to that siloed lack of communication. You may have been put on something for an ulcer by a GI guy 8 years ago, and nobody ever took it off of your drug list. So it keeps popping up and you're on it. You're like, why am I still on this? Why am I still on this? And you keep taking it. And then the cardiologist adds on something. And then the pulmonologist adds on something. They don't reconcile these drug lists. They don't know. So occasionally it's good to talk to a pharmacist and take your medication list and just say, are there any potential drug interactions here? And this one, the beers list, sometimes as we age, not sometimes, all the time, as we age, our metabolism starts to break down drugs differently. And so a lot of times there's drugs that shouldn't even be prescribed to an elderly population. And there's other drugs that there's a significant dose reduction or a different way that you may give the drug in an elderly population. So no longer can we just kind of sit in the back seat of the car and let everybody kind of just drive and tell us what drugs to be on. We need to sort of be on top of that as well. I just mentioned, don't ever go out to a discharge in the hospital or somewhere. Don't be afraid to pull out your phone and say, may I record this? That's an invaluable thing to have later. And finally, I mean, don't be afraid to ask for help. My parents were very, and I think a lot of folks in this generation, just private, and healthcare is very private. And when you're sick, it's very vulnerable. You feel very vulnerable. So this takes a little discipline to push through that and go ahead and ask people for help. Ask people you trust, friends, family. And if you don't have somebody, or you would like a third party because you don't want somebody all up in your business, then get a professional independent advocate to help you. The way you can do this, one of the ways, this is the Advocation Directory. So to answer your question about finding an advocate for insurance, finding one for, there's advocates that do geriatric care, there's advocates that do cognitive disabilities, there's people like me that do cancer. You can go and you basically can search based on your geography or what you're looking for. Find a couple that you like, interview them. This particular site will give you a worksheet on how to interview an independent advocate and get some help. Another way you can get some help, I'm also a community educator for this particular organization. It's a nonprofit. It's called the Care Partner Project. Karen's the executive director of this organization, her whole mission for being is to protect people from harmful things that should never happen in the hospital. Her dad had a very horrible interaction with the healthcare system while he was in the hospital. And so her life's mission is to protect people. And she has I can't even tell you a plethora, a myriad of resources on this website in the way of checklists that you can go. So if you know you're getting ready to interact with the system or you're going to be a care partner for somebody else, you go to this site, you can pull down checklists that will help you know what to say, when to say it, what to look for, how to interact with the nurses. This is a valuable, valuable website. So I'm going to stop there. Holy cow, I talked a lot. But if y'all, and I want to leave time for discussion, but if you guys feel like this was valuable, I'm happy to share this with anybody that wants to have me come share it. So I will just be quiet now. And let
this is great, Dana. And I'm dropping your contact info into chat one more time there. And we've got some comments and questions that I want to make sure that we address. Let me get up there. Okay, let's see. Whoops. Okay.
I just stopped sharing so I could chat.
No, this is great. Okay. Dixie says, doctors must hate you, but patients surely love you. Patient-directed care. Please teach medical school. One of the best. Oh, thank you. I agree. One of the best positive aging programs ever. Your granddaddy doctor lives on in you, Dana.
Oh my gosh.
But yeah, like, do you ever get blowback from healthcare professionals?
Oh, that is what is so interesting. Physicians, a couple, two things. One, if they're really upset that you've got somebody with some insight with you, that's a red flag. But sometimes I will say these doctors, they're usually very receptive, because usually if you've got an advocate with you, you're a very informed healthcare consumer. And so they love you because their time is maximized. They're not wasting time on things that are just kind of, you know what I mean? So actually they do appreciate us. I have had a couple guys push back. They didn't say I couldn't be there, but I think what it is some of them, it's hard for a lot of these guys to stay on top of everything that's happening. And some of their insecurity comes out in sort of anger, right? Because they're afraid that, oh my gosh, this person's going to know something I don't know. They're going to ask me a question. I don't know. So, but to answer your question, Dixie, most physicians totally love having informed healthcare people.
Great. And I see Stephanie has her hand raised, so I'm going to allow her to talk, but then I'm going to also read another comment that says, Chuck says, portals do not need to be historical only. Using ongoing medical treatment can be valuable. And he was very happy that you brought up using portals in communication.
Oh, there's something, you guys, there is something that was passed, I think 2 years ago. And it was I'm going to put it in, I'll put it in the summary sheet, but your notes, some portals are better than others. And you're right. Like, we should use them going forward too. It's not just in the past. It's a great way to communicate with your doctors too, but not all doctors put your clinical summaries in the portals, and they by law now have to. So if you're not seeing a clinical summary, if you're just going your portal and you just see a bunch of lab values of like what your blood work looked like, and there's no like summary of what happened, that's not okay. You have to have easy access to your clinical notes. So thank you for reminding me of that. I'll put that in the summary.
Great. And then I think you brought this up, but Elizabeth was asking, do you need authorization to record a conversation? You had mentioned recording.
Yeah. It depends on where, like, you can't do it just I'm just going to under the table. I'm just going to record. Usually if you just ask them, may I record this? 9 times out of 10, they're going to say yes, because they know why you're doing it, right? It's not because you're trying to catch them in something or do something. You're just tell them, I'm not going to be able to retain all of this. I need something that I can refer back to once I get home.
Okay. Oh, this is a great question from Rebecca. She says, when is it worth seeking an out-of-state doctor for a second or third opinion, or reach out to the Mayo Clinic or Johns Hopkins? You hear about this happen so much, and quite honestly, I had some eye issues where I went up to Hopkins. Your thoughts on this?
That's a great question. I do have thoughts on this. So the one I will say, if you're diagnosed with something relatively rare, okay, and that it's just not seen all the time, you need to get in front of the person that sees it all the time. For instance, if you have a cancer diagnosis where it's like maybe, 1% of 100,000 people see it in a year, that means the general population of oncology people are not treating that. Right? So you need to find where is the one center and the one person that is seeing all of that kind of cancer, because then they have the perspective, they know the research, they know how to do it. So in instances where you're dealing with a rare situation, you need to go wherever that is. And a lot of times you need I'm just going to tout my own horn. A lot of people need an advocate at that point. You need an independent advocate, because I have the whole country perspective. I'm not just dealing with what's going on in Virginia or what's going on in Maryland. Like, I know what's going on everywhere. So I know where that center of excellence is, or I know how to find it. So I hope that answers your question.
I agree. And I discovered it firsthand with a rare eye condition at these centers of excellence. I like that you framed it that way. These doctors, they don't want an easy case. They want the challenge, and man, I'd never seen a team of physicians like I had at Hopkins. I mean, they run it through. It's pretty impressive. Okay, let's see. Will says, do you advocate for long-term care patients in the hospital until they return to a nursing facility? And as we had said, Dana personally focuses on cancer, but patient advocates are out there advocating at every healthcare setting, correct?
Oh, yeah. So a couple things. So one, you can get a private advocate like me. And I have advocated for some of my clients that find themselves in the hospital from long-term care, like they're just in the middle, so I have done that. But there's two ways you can do it. One, you can find a private advocate that will go help you. And they're all over the place. So if you need somebody bedside, you search by geography, right? But not everything has to be done bedside. I've got clients all over the country. Another thing to do is, if that's not an option for you, because we are a fee for service. I mean, we charge, but you want us to, because you want us working for you. You don't want us working for the hospital, or you don't want us working for the health or the insurance company. But if you have to have an advocate inside an institution, most hospitals now have patient advocate services. So you can contact patient services and get an advocate that can be there and be the eyes and ears for your loved one while they're in the hospital, that can coordinate care and coordinate all of that for you. So there's two ways you can do it. You can get independently, or you can use one of the patient services inside the institution.
Yeah. And then also, like for Willister, I don't want to neglect mentioning aging life care managers, because oftentimes, especially like if you're leaving the hospital and going to assisted living or a long-term care, skilled nursing, the ability to have a care manager helping you implement that plan, they're advocating the same way Dana is, you know.
100%. And I work with several of the geriatric and the aging care managers in everywhere, because they're part of the team that I'm helping people put together. And sometimes an aging care manager will call me in to be like, this, we've got a cancer thing. I don't know, like, can you come in and help us with that? So we work very, very much as a collaborative team.
And I just glanced at the clock. I knew this one was going to go over an hour, but I really think that Elizabeth's comment here is a great way for us to try to wrap things up. And she says, "Thank you for empowering us. I used to be afraid to ask questions out of respect to the doctor and trust them. I'm an immigrant to this country and helping my community." And I do feel that, Dana, that you really, your presentation has empowered us to understand that we can ask questions, to know that you don't need to walk this road alone. And the one thing that hasn't been addressed, and I'm surprised, because I had mentioned solo aging is our number one topic on these discussions, is that there's a lot of folks out there that are concerned about who's going to take care of them in the future. Do you and your colleagues ever have people, reaching out now and sort of saying, "Hey, Dana, I don't know what is in my future, but I want to get to know you in case something happens to me, that we have a relationship and you can advocate on me if I'm in the hospital"?
Gosh, that's so good. That it's something we talk about all the time.
But it probably rarely happens, but it's something that
is, Steve, is people, none of it, it's human nature.
Oh yeah.
We're not going to need anything. It's why we don't talk about, what we want for our end of life wishes. It's why we don't talk about any of it, because it's not pleasant. We don't want to talk about it. One thing that I have done, and I will say, is I'm trying to make some connections to be a resource for people like estate planners, attorneys, people that where solo agers are going to like get other things in order for themselves, where their professionals know about us, so that professional can make the referral to the solo ager should the need arise. And I also do a lot of community speaking where I try to just connect, with some of like this organization. You do such great work, Steve. And so, we're trying just to get the word out there that we're here and that, we want to help.
Yeah, I like that idea that, if you're creating your estate documents, your healthcare and financial power of attorney, it's a great idea to just do some research, because let's say somebody is handling your healthcare power of attorney, what a great gift to give that person is, I already have a pre-existing relationship with a patient advocate, because we turn our lives inside out if mom or dad or our best friend is made me healthcare power of attorney and now she's in the hospital, Right. So it's the cool idea in concept. I see Louis Tenenbaum is on the call. We talk about remodeling our homes before we really need all of these things. If we can create a shift to get people to think about this stuff.
It's a mind shift. Well, one thing I will say, Steve, if it's okay, if anybody wants to be on a newsletter, I have a newsletter. I don't spam you. It's like once a month, and I try to put in good. It's not all cancer related. If you want to be joined up with that, we can stay connected that way. And please, if y'all know anybody that is going through anything, even if it's not cancer, reach out to me, because I can connect you with the right folks. So don't hesitate to share our information.
I love it. So what we'll do, I'm going to upload this recording. I'm going to have all of Dana's contact info there, so you can hit her up with, if you want to be on the newsletter, if you need more info. You're going to get me the summary, and I'll make sure that that's live on the site as well. And I knew this was going to be a great discussion today, Dana. I really appreciate you coming on. And once again, I mean, you're the star of the show, but the second the questions that the audience gives always really warms my heart because we're answering your questions.
Yeah. And you're engaged. I love it. You guys are like halfway there.
Yep.
More than halfway, 3/4.
Oh yeah. Yep. So, all right.
Thanks, Steve.
See everybody soon.
Okay, bye-bye.